All right, well, good evening, everyone. Welcome to our penultimate class session. So this is our second to last session. I hope everyone had a very good and restful Thanksgiving break last week. We have class tonight, and then we have class next week on the 9th, and then that wraps it up for us. So it will be nice for us to actually be together 2 weeks in a row. I know that's been kind of rare, the way in which this semester has worked out, but again, it is what it is. But welcome back. I hope your semester is wrapping up well for you and your other classes are wrapping up quickly. I thought that what I do is just do a real quick reset since we're now almost at the end of the class and just remind you of your final assignments that are due next week and how we'll handle our presentations moving forward. And then once we get done with that quick reset, then we'll spend some time talking about healthcare policy, spend some time talking about welfare policy, and then we have 4 folks who have volunteered to do their presentations this evening. And so the last part of our class tonight will be those 4 presentations. And so that's what's on our agenda for this week. Next week, then, in our last class session, we'll reserve the entire time just to student presentations. So if you're not one of the 4 people presenting tonight, that means by definition, you'll then be presenting next week. But let me talk about the final report that's due next week, your final beach board essay, and then another quick word or two about the presentations and how they work. So the final report that is due next Thursday, 12/9 by 11:59 p.m., that is your post-instructional assignment. So when it comes time for you to turn in your student learning portfolio, in part 2 of your portfolio for your PPA 670 class, you'll have your first paper, which was your pre-instructional assignment, and then you'll have this final report as your post-instructional. Now, again, for this post-instructional, there's not a lot of new things that you will be doing to complete this final report. The final report will consist of a title page, then give me a 1-paragraph abstract to describe what's going on in this final report. Then you'll put in your first paper, that background paper that you prepared and submitted weeks ago. That will then go in as part of this final report. Then you'll put in your second paper, that annotated bibliography alternative type of paper will go into the final report. And then the new thing that you'll be creating for this final report will be a section on your chosen alternative. So whichever alternative or alternatives plural you are selecting, you'll give me a discussion of those alternatives or that alternative, what's comprised of that alternative, why you selected it, and that will then be this new section that you'll be adding into this final report. And then at the end, of course, is always a reference page. The way in which I'm going to evaluate this final report is I'm not going to really spend a lot of time with the first and second papers because I've already reviewed those. You're just basically putting these in. Where I'm going to spend most of my time and most of my focus will be on that chosen alternative section. And again, that chosen alternative section, the length will vary depending upon whether you're advocating one solution or multiple solutions. The more solutions you're advocating, obviously, the longer it's going to get. If you're only advocating one solution, I would think this chosen alternative section you're probably looking at maybe 2 pages, 3 pages, something like that. It doesn't have to be too lengthy. Just give me a good justification for why this alternative that you are selecting is superior to the other alternatives that you offered up in paper number 2. So that's this final report that you'll be turning in again by 11:59 p.m. Next Thursday, December the 9th. So any questions on that final report? Okay. Seeing none, then
Hi,
also, I'm sorry, go ahead.
I'm sorry, Professor. Yes, I have a question. So for our second paper, we offered up alternatives or what we decided that could be beneficial for our societal problems. So with this new paper, we're just emphasizing the solution that we would pick and why. Is that I just want to get a clarification.
Yes, exactly. You'll just, from those alternatives that you offered up in the second paper, you'll be selecting at least one of those alternatives and then justifying why that's the most appropriate alternative.
And it's okay if we do more than just one, correct?
Absolutely. Yeah, and it's very common for folks to do maybe two solutions and say, yeah, well, in order for this one solution to work, I need to also have this solution as well, because they kind of are work together. They dovetail together so well. So it's common for people to have a hybrid of two solutions instead of just the one.
Yeah. Okay, because I want to get your feedback on what you think, advise what I could do. Because for my paper, specifically, I centered it around racial discrimination, and healthcare, education, and housing. And so when I've been writing my papers, I've been focusing on centering around those topics, and then giving alternatives for that. So do you think it would be appropriate if I just continue with finding the solutions for those three main components?
Sure. Yeah. And it may have, since you got those three main components, you may find it necessary to have, three solutions that you are offering up as appropriate solutions. If you've got a solution that may help remedy two of those three, then maybe you only need two solutions. But it sounds like in that situation, you are going to probably have multiple solutions that you are advocating for.
Okay, sounds good. Thank you.
Sure. Absolutely.
I also had a question. Oh,
Go ahead.
oh, thank you. So for the other paper, we offered three solutions. If we found a better one that wasn't in that paper, can we include it?
Absolutely. Yes.
Okay.
And that's a really good question. That, yeah, in your continued research into this topic, if you have found another solution, or you brainstormed a solution that's better than you think the three that you've already offered up, you can certainly give me that new solution and explain to me why it's better than the three that you offered up in the second paper. Yeah. Okay.
I just had one quick question. So in the order that they go in, the annotated bibliography goes before the alternative, or it goes after?
It goes before your chosen alternative. So the way in which it goes, title page, abstract, your first paper, your second paper, which is the annotated bibliography paper, then a new section on which solutions you're choosing and why, and then a reference page.
Okay, perfect. Thank you.
Sure. Good questions. Any other questions about the final report? As always, if a question emerges that you don't think of tonight, but you think of in the ensuing days, you can always email me. And I think you've seen I respond to emails relatively quickly. So happy to answer any other questions that may pop up between now and next Thursday. The nice thing about the assignments due next Thursday is, once you've got your final report done, then you also have your fifth beach board essay done as well, because the fifth beach board essay, as you know, will just be you sharing with the class in beach board in the discussion forum what is your chosen solution and why you selected that solution. So Francis, go ahead. You have one more question?
Hi, yes. Do you have an example of the format, or should I just look at Purdue OWL?
In terms of doing the citations, Purdue OWL is a great
No,
place
I'm
to
sorry.
go.
I meant of the whole paper.
I don't really, I could try and dig one up and take off identifiers. The problem with using that is, I have to then contact the student who submitted, even though I'm taking off their name. I still ethically need to contact them and say, oh, by the way, I'm sharing this with another class section. So I can look into that and see if anyone from a previous class section is willing to share.
I just wanted to see if the abstract is its own page, or we just continue off the abstract and then
yes,
like a continuous paper instead of one page for each section.
You don't have to rewrite everything to make it flow as one continuous paper. You don't have to worry about doing that. I mean, you can literally just title page, and then on a separate page, your second page would then be your abstract, that one paragraph synopsis. And then it'll just be your first paper, your second paper, and then the new section on your chosen solution. But you don't have to go and rewrite to make the first one flow into the second, you don't have to worry about doing that. Literally put the papers in as you have them.
So does the abstract and background can go on the same page, or abstract one page, background second page?
Abstract one page and then background.
Understood. Okay. Thank you.
Sure. Okay, so you got those two assignments, the final report and then your fifth beach board essay due next Thursday. And next Thursday, as I said, will be our final class session. Just another word or two about the presentations. We talked about this 2 weeks ago, but just a reminder, they're informal, they're very brief. We have 4 brave souls who I appreciate were willing to go tonight. That means we're going to have about 16 or so presentations that will be going next Thursday. It's a good number of presentations to do within that class period of time. So we're going to really limit them to 5 to 10 minutes. And so once we hit that 10-minute mark, I will flag you down and let you know that you're at your 10 minutes and you'll need to wrap it up. But they're very formal, very quick types of presentations where you'll talk to us about, here's your societal problem. Here are the possible alternatives that you thought about, the stakeholders who are involved. Here's the alternative that you selected, and this is why you selected that alternative. And that's it for the presentation. You're welcome to use PowerPoint, but you are not required to use PowerPoint. If you do want to use PowerPoint, a lot of people like to use that to help guide their presentation. That's absolutely fine. I have enabled tonight's session and will enable next week's session so that everyone can share their screens. So whenever it comes time for your presentation, if you have a PowerPoint presentation, you can just hit share screen and you can share it out and all of us can see it. If for some reason you're not comfortable doing that and you'd rather me do it for you, you can always submit your slides through our Beachboard page, and I've got a Dropbox for a PowerPoint presentation. You can submit it there, and then I can load it up on my computer, and when it comes time for your presentation, I can share it out for you. The only drawback to that is if I'm sharing your presentation, you'll just have to let me know when to move slides, because I'll then be controlling the presentation. But it's up to you. You can either share it out yourself or have me do it, or not use PowerPoint at all. There won't be any point deduction if you don't use PowerPoint. That's completely optional for you. So those are the presentations. Again, the lion's share of those we will be doing next week. We don't have a final exam in this class, so I guess that's something to celebrate. So we won't have to worry about having a final session where you sit and do a final exam. So next week will be our final time together. Okay. All right. Again, any questions about any of this, feel free to shoot me an email and I'm more than happy to respond. Let me go ahead and open up our health policy slides. I don't want to spend a whole lot of time going through this tonight. I think that it is important in a class like this that we do spend time on each major policy area. Now, we don't have time for all the policy areas. So tonight I thought we'd do healthcare policy and then wrap it up with welfare policy. I don't want to dig into a lot of the details in either healthcare or welfare policy, but I think it's important that we do talk about these different discrete policy areas, because obviously the stakeholders will differ between healthcare policy versus welfare policy. The goals and objectives will differ depending on policy area. The way in which we design the policies will differ depending upon what policy area we're talking about. So I do think it's important to kind of show some of those differences across these different policy areas. We spent some time already talking about economic policy, talked about fiscal and monetary policy. We spent time talking about education policy, and I've read your responses to date in Beachboard essay number 4, where you offer up 3 different alternatives to improving the quality of K through 12 education. And any of those posts that were done before 6 o'clock tonight, I've already gone through and read and provided feedback and a grade to you. If you haven't done that Beachboard essay number 4 yet, do make sure to get it done by 11:59 tonight, and I'll get you some grade and some feedback on that. But we've already covered those policy areas, so we'll start off tonight talking about healthcare policy, probably then take a break after healthcare policy, and then come back to welfare policy, and then our 4 presentations. So in healthcare policy, this is obviously a hotly debated topic. And with the Affordable Care Act in the Obama administration and multiple attempts to unwind the Affordable Care Act through both legislative action in Congress, as well as through cases in the Supreme Court, we've really, shone a light on this idea of healthcare policy. And then we got hit with the COVID-19 pandemic. And when the pandemic hit over the past year and a half, 2 years, we really started to pay very close attention to healthcare policy, who is involved, why they're involved, and how we make changes in terms of how we put healthcare policy together in this country. So this has really become a real hot button topic, obviously, over the past couple of years. There are a couple different ways you can look at healthcare policy. You can view healthcare policy through a very narrow lens or through a very broad lens. If you look at healthcare policy through a very narrow lens, you're focusing primarily on the major healthcare programs such as Medicare and Medicaid. So sometimes when people talk about healthcare policy, they're talking about changes needed for Medicare and Medicaid. And we'll spend some time distinguishing between Medicare and Medicaid tonight and talking a little bit about how those two programs work. But there's also a very broad way of looking at healthcare policy. And the much broader approach to healthcare policy is you define healthcare policy not as discrete programs like Medicare and Medicaid, but rather you define healthcare policy as all government actions that affect public health. So a decision made by the FDA or a decision made by the CDC would fall under healthcare policy with that type of definition, even though it may be outside of the parameters of Medicare or Medicaid. I think for our discussion tonight, it's important for us to kind of shoot for the middle. So we're going to talk about Medicare and Medicaid, but we're also going to talk about other aspects of government action in the area of healthcare that could also be considered healthcare policy. So we'll talk about CHIP, and again, the Affordable Care Act. We'll talk about veterans care, and we'll talk about some ways in which we try to improve the care being provided. So we'll kind of take a more holistic, broader approach to dealing with healthcare policy. We talked early on in the class about this idea of policy formation and how policy formation doesn't just occur in legislative bodies. In your high school civics class or your undergraduate American government class, you probably talked a lot about, separation of powers. And you talked about the legislature being responsible for, passing laws and the formation of policy. But we know as students in the public administration program that we as administrators make a lot of policies. We engage in a lot of policy formation outside of legislative bodies. We do it through rulemaking. We do it through, putting together implementation procedures for how we're going to implement these different policies passed by legislatures. There's a lot of policy formulation that goes on within agencies. That was very clear to us during the COVID-19 pandemic with the FDA and the CDC. And whenever we would have a new vaccine that was introduced and would go before the FDA to get either emergency approval or to get full approval, those decisions made by that agency really certainly fall into this parameter of healthcare policy. They're making policy about which vaccines are considered to be safe enough to be given to adults, which ones are safe enough to be given to 12 to 17-year-olds, which ones are safe enough to be given to 5 to 11-year-olds. And the trickle down of those decisions will be profound. And we've seen that in terms of the operation of education in our schools. And so the way in which you run an elementary district is going to be different than the way in which you run a high school district because of the availability of these vaccines for younger students compared to older students. So the FDA had a lot to say with that. The CDC then had its role to play in terms of how these vaccines get rolled out and when they get rolled out and which vaccines have approval by the federal government, which do not have approval. So we saw a lot of this policy formation going on within these health-related agencies at the federal level. Healthcare policy has gone through an evolution. Early healthcare policy in this country was really focused on trying to prevent and mitigate catastrophic losses. Today, healthcare policy is much more insurance oriented. And today in this country, the vast majority of Americans get health insurance through their employers. And so it's employer-sponsored healthcare insurance. And that's kind of the focus that we have here in this country that sets us very much apart from our counterparts in Canada or our counterparts in Europe, in that we have this employer-sponsored type of insurance program where everything is more down to the level of employer. And so you get your insurance through your employer, rather than getting your insurance through a single payer type of system or some type of national insurance, health insurance type of structure, like we see again in Canada and like we see in some of our European counterparts. So it's really that employer aspect of health insurance that sets us apart from a lot of other industrialized democracies. Healthcare policy really, the roots of the modern healthcare policy approach came from Medicare and Medicaid when they were created under the Social Security Act amendments. We then saw a major change in the evolution of healthcare policy in the Obama administration with the passage of the Affordable Care Act. We saw the Children's Health Insurance Program that really grew in the 1990s and grew again in the Obama administration. The Affordable Care Act, Children's Health Insurance Program, as we know it as CHIP, they're really designed to accomplish a variety of different goals. One goal of the Affordable Care Act and CHIP and other programs such as that are to try and enhance the efficiency of healthcare service delivery, to try and reduce some redundancies and duplication in the delivery of healthcare, and to try and make the delivery of healthcare more efficient and a little bit more commonsensical. So to try and untangle the web of all these different actors who are usually involved in the provision and production of healthcare services. Secondly, a second goal of the Affordable Care Act and CHIP and other programs like it, always to try and reduce costs, to try and make healthcare a little bit less costly. And we'll see in a few slides a good graphical example of just how exponential the rise has been in the cost of healthcare services over the past 40 years. But number three, and probably most prominently, the Affordable Care Act was really designed to try and enhance coverages and to try and cover more and more Americans and to try and provide coverage to those Americans who are either uninsured or underinsured. And there is a difference between being uninsured and underinsured. And it's kind of commonsensical probably, but uninsured lack all healthcare insurance. They lack all healthcare coverage. Some folks, though, do have healthcare coverage, but it's not adequate to meet their needs. And those are the folks we refer to as the underinsured. So the Affordable Care Act was meant to try and expand coverage to both the uninsured as well as the underinsured. It's probably the primary goal of the Affordable Care Act. So with the Affordable Care Act, we saw this pronounced increase in the idea of government intervention, at least in terms of the provision of healthcare. And as we've talked about in a previous class, there's a difference between provision and production. Provision is providing the resources that make production possible. Production is the actual creation of the service or the good. So with healthcare, especially in terms of federal intervention in healthcare policy, we are typically looking at provision, providing the resources, providing the payments to doctors and the payments to hospitals and pharmaceutical companies, providing the resources as opposed to taking over ownership of the production of healthcare. So you don't necessarily have, government doctors outside the VA who are providing healthcare or who are giving healthcare services. So it's much more provision than it is production. But when you have something like the Affordable Care Act and the establishment of all these different healthcare exchanges in the states all across the nation, you have a pronounced increase in the role of the national and state governments in the provision of healthcare. The question then becomes, how involved should governments be in the provision of healthcare? And I think in this country, we kind of are of two separate minds on this type of issue. I think a lot of Americans view healthcare as being what we call a merit-based good. And with a merit-based good, what we mean is that the private sector and private market forces should not fully determine how the good is allocated to Americans. So we don't want to just turn over healthcare to the private sector and allow private sector companies to determine who gets healthcare, who does not get healthcare, how much healthcare this person gets versus how much healthcare this person gets. We don't want to do that. But we're also hesitant to turn everything over to government because people tend to like their current insurance. And their current insurance is coming from their employer-sponsored programs. They tend to want to keep their employer-sponsored programs. And you see this play out politically in elections. And you'll see Democratic candidates talk about, well, the private sector shouldn't be determining who gets health care. And then you'll see Republicans say, the Democrats are trying to take away your health care. And they're trying to take away your choice and not allow you to keep your current health care plan. Again, it's become a very highly politically charged type of topic, but I think where we come down as Americans is we come down somewhere in the middle, where we think there should be a role for government to play. We can't leave it all to the private sector, but we tend to really like the plans that we currently have. We don't want government coming in and taking those insurance plans away from us. So what that has given us with healthcare policy is it's given us a policy that's really geared toward government role as being filling in the gaps in private insurance plans. So kind of this stopgap type of approach has been the way in which we have approached the role of government in the provision of healthcare policy. Again, when government gets involved, when government intervenes, it oftentimes intervenes, like in the Affordable Care Act, to try and expand coverage to those individuals who are either uninsured or underinsured. Because we know there are some very profound impacts for being both under as well as uninsured. When you're uninsured, you may get very little to no care whatsoever. If you're underinsured, you're probably going to get care that is not as adequate as you need for your medical conditions. Whether you're uninsured or underinsured, it probably means you're going to get less care for chronic diseases. And this is the problem that is self-perpetuating, is if we are not properly and appropriately addressing these chronic diseases, then these chronic diseases are going to continue to worsen, and then the medical problem becomes worse in the future. And so it's kind of a self-perpetuating type of prophecy. If we don't deal with the chronic diseases in the beginning, they're just going to compound and become exponentially worse and more expensive and harder for us to treat. So we have this duality in our healthcare approach, whereby we believe there is a role for the government to play, but it is a more limited role than what our counterparts in Canada and European nations oftentimes believe. What this duality approach has given us with our healthcare system is it's given us a healthcare system that is very good in certain respects on certain indicators, but has problems on other indicators. So where our healthcare system is very good here in the US is in terms of indicators such as the number of physicians per capita. So you look at per American and the number of physicians we have per American, our ratio looks a lot better than a lot of other nations around the world. When you look at the number of specialists we have, people fly in from all around the world to the US to see medical specialists because we tend to have more medical specialists here in the US than other countries have. And we also have a broader variety, if you will, of different medical specialists. So we tend to do very well in terms of specialties. We also tend to do very well in research centers. We have some of the largest, most well-funded research centers here in the US as compared to other countries. So there are some things we do tend to do very well with our healthcare system, but there are some other things we don't do quite as well. So as I said before on the previous slide, we have less care for chronic diseases than you oftentimes see in other countries. And we also have less care for vulnerable populations. There tends to be more health disparity in the US than some other nations based upon socioeconomic status and based upon income. And so vulnerable populations sometimes don't fare as well here in the US as compared to their more affluent counterparts. So there are some good aspects, there are some bad aspects as well. So how do we do healthcare in this country? Well, we have two primary programs that really underpin our healthcare policy, Medicare and Medicaid. And again, I don't want to spend a lot of time going through the details of both of these programs, but it is important to distinguish between them because these are the two basic drivers that we have for our government healthcare programs. So the first program is Medicare. You're probably all familiar with Medicare. Medicare provides medical coverage for older Americans, typically 65 and above. The provisions of Medicare, you've got 4 different possible parts of Medicare. Not everyone has all 4 of these, but the 4 possible parts of Medicare are Part A, Part B, Part C, and Part D. Medicare Part A, that's for your long-term stay. And so that's to help you cover hospital stays. It's to help you cover the first 100 days of a stay in a nursing home. That's for your long-term care. Medicare Part B is there for your outpatient services. And so you have co-pays for your primary care physician. It will help defray costs of tests, other types of outpatient services. And so this is where you do your deductibles and your co-pays is Medicare Part B. Medicare Part C is for managed care programs that are run by private organizations or sometimes nonprofit organizations that contract with the federal government in order to provide some of the, to fill some of the gaps in Medicare coverage for older Americans. And so you've got organizations like, it could be a managed care organization like Aetna that will sign a contract with the federal government to help provide some of these services not being provided by Medicare. There's a major nonprofit organization located here in California called SCAN. And SCAN does the same thing. It just does it on a nonprofit basis, whereby Aetna does it more on a for-profit basis. But these companies, these managed care organizations, sign contracts with the federal government to then try and fill in some of the gaps not currently being provided to patients by Medicare. Then you have Part D, and Part D is for prescription coverage. Again, not everyone has this, but Medicare Part D will defray some of the costs of your prescription medication. Medicare has been around for decades. And like any other program that's been around for decades, there's been a lot of time for people to figure out how to engage in fraud and abuse the Medicare system. And so you have things such as overbilling, where you may have health facilities or physicians that overbill. Medicare, what they will do is Medicare will provide a maximum amount of reimbursement based upon different types of procedures. But what physicians can sometimes do is they can reclassify a procedure as something else that then gets a larger reimbursement. Or sometimes they will submit multiple reimbursements for the same type of procedure. We have seen sometimes in the past where physicians have actually made up procedures that they didn't actually do and then charge for Medicare reimbursement of those types of procedures. So there's a lot of fraud, there's a lot of abuse, as with any government program that's been around for decades. A lot of folks in Congress have talked about reforming Medicaid through the use of vouchers. You know, just like you would use in housing policy or like you use in education policy, you can use vouchers here in healthcare policy as well, where you provide vouchers to Medicare recipients, and then Medicare recipients can take those vouchers and then choose which doctor they want to see and which procedures they want to have and use those vouchers then to pay for those procedures. The big advantage of vouchers is portability, in that vouchers can travel over state lines, and you then get a choice of which physician you want to use in order to cash in your voucher. The problem with vouchers is, of course, the idea of equity, and it can actually create even more fraud. But that's one of the calls in Congress, is to reform Medicare in order to make it a voucher-based type of system. Then in addition to Medicare, you then also have this program known as Medicaid. And Medicaid, whereas Medicare is for older Americans, Medicaid is for Americans under a certain income eligibility level. And so it's for, I hate the term poor, but it's for poorer Americans. So for Americans from lower income strata. And that's the big difference between the two. Medicare is primarily for older Americans. Medicaid is more of a means-tested program for poorer Americans and Americans with disabilities. Medicaid, the benefits you get from Medicaid as a Medicaid recipient will oftentimes depend upon where you live. And there's great variability in Medicaid services based upon state. And so the Medicaid reimbursements you may get in California are probably going to look a lot different than the Medicaid benefits you're going to get in a state like Mississippi or Alabama. Sometimes state Medicaid provisions are actually more generous at the state level than they are at the federal level. And that's true for a state like California, not true for a state like Mississippi. Some governors, especially Republican governors, when they were given the opportunity from the federal government to expand Medicaid coverage, they chose not to. And with that choice of not expanding Medicaid coverage in their states, that's what's given us even more variability in terms of the Medicaid coverage between different states in the country. So there's a whole lot of variability involved. So just being an American doesn't mean you're going to get the same Medicaid coverage if you live in one state versus another state. And a lot of the same fraud and abuse issues we talked about with Medicare, we also see evident in Medicaid as well. So again, as I said before, any large government program that has been around for decades, you're probably going to have these types of instances of fraud and abuse. Again, voucher system is another way in which Congress has talked about making these modifications to the Medicaid system. But again, that's the primary difference between Medicare and Medicaid. Medicare for older Americans, Medicaid for poorer Americans and Americans with disabilities. Another area of focus in healthcare has been programs for veterans healthcare. And this has, again, been a very frustrating area of healthcare for a lot of policymakers because we've had a lot of issues of veterans not being able to get adequate care, veterans not being able to get adequate care in time, in that they are not able to get to see a doctor for weeks or months. And when they do get that care, the care is certainly substandard care. And so there have been a lot of concerns about the care being provided to veterans. We won't get into a lot of the details of VA care, but there was a major piece of legislation in 1996, the Veterans Healthcare Eligibility Act, and that Reform Act, and that piece of legislation tried to make a whole-scale change to the way in which healthcare is provided for veterans, changing the types of services provided, trying to change the co-payments that are required for those services to, again, try and make healthcare more accessible and at a lower cost for veterans than what we saw prior to that reform effort. A large part of VA care today, veterans healthcare today, comes from a program called TRICARE. And TRICARE was created several years ago, and the initial goal of TRICARE was to provide healthcare coverage for retired veterans who had not yet reached 65 years old. Because if they have not yet reached 65 years old, they did not yet qualify for Medicare. You had a lot of folks who were joining the military service at a very young age. So they would enlist in the military at age 20 or 21, and they would have 20 years in and would then be eligible to retire by their early 40s. But then they had this gap between their early 40s and 65 before they would be eligible for Medicare. So we created this program called TRICARE to try and expand healthcare coverage to those retired members of the military and their families, their dependents, when they did not qualify yet for Medicare. That TRICARE program has really expanded over the past few years. And so now it's not just for retirees, but now TRICARE has been expanded to include members on active service in the military. And so it applies to the vast majority of folks in the military. And now the focus of TRICARE has really turned more towards specialty care. And so you get your normal care from your military service and from the Veterans Administration, but then you can get specialty care beyond just your VA benefits through this program known as TRICARE. But it has been a struggle to try and address some of the shortfalls that we have seen in the veterans healthcare system. Some of the other ways in which we try to address some of those shortfalls, changes in management. We saw in the Trump administration that President Trump fired the VA secretary and hired a new VA secretary because of, again, some of the long wait times for care, some of the substandard care that veterans were receiving. So we tried new management at the VA in the past. And President Trump wasn't the only one who ended up firing a VA secretary. We saw that happen in previous administrations as well. Another way we've tried to address some of this substandard care is through more money. And every new budget, we put more money into Veterans Administration and Veterans Healthcare Services. Recently, there have been more calls for privatization, where some advocates of privatization will argue the problem is that the Veterans Administration is a large, bloated bureaucracy. And so instead of having this large bureaucratic organization in charge of healthcare, we would privatize some of these services. And so it wouldn't just be VA doctors, but you would privatize and you would contract out with other private sector physicians and private sector hospitals to provide care for our veterans. And so a lot of different alternative solutions out there that we have tried and we are probably going to try in the future to try and remedy some of these problems with veterans healthcare. Another major issue we're trying to remedy is the issue of portability. You know, one of the problems we have in healthcare is that healthcare is not always portable. So if you move from one state to another or from one employer to another, you may end up losing your healthcare. And so we've tried to enhance the portability of healthcare. So we have the Health Insurance Portability and Accountability Act, otherwise known as HIPAA. And you're probably familiar with HIPAA and some of the privacy aspects of HIPAA. But not only did HIPAA provide some privacy to medical records, but also HIPAA provided a little bit more portability. So that if you move from one state to another and you are switching your healthcare coverage, there will be a grace period where your former healthcare coverage will continue to cover you until your new healthcare coverage kicks in. COBRA is another example of portability, but this is portability for moving from one employer to another. Since most of our healthcare plans are employer sponsored, if you leave your employer and you take a new job, you're going to lose your healthcare with your previous employer. Well, COBRA allows you to keep your insurance with your previous employer for up to 18 months upon separation of employment. So it gives you that additional 18 months then to find another job and to find another insurance plan. So again, it's important that we try and keep people continuously covered by allowing them to have portability, not just from one state to another, but also portability moving from one employer to a new employer. The big problem, though, that we are facing with healthcare policy is obviously rising costs. And the table on the screen will really illustrate this well. So if you look at from 1980 to 2017, and then the estimate for 2027, you can see that regardless of the indicator you use, healthcare costs are rising at an exponential rate. So in 1980, the total national healthcare expenditure in billions of dollars was $255.3 billion, which sounds like a lot of money. But compare it to 2017. In 2017, that $255 billion in expenditures has now gone up to $3.492 trillion. So it's gone up to almost $3.5 trillion in the span of 37 years. And then look what we are forecasting it to do in 2027, go up to almost $6 trillion. So the problem here is not only is it rising, but the trend is going up at a very quick rate in that the increase is accelerating. Look at it in terms of per capita healthcare expenditures. So healthcare expenditures per person, per American. In 1980, it was $1,108 per American. In 2017, $10,739. So it's increased by 10 times. You look at 2027, projected to go up to almost $17,000 per person. Healthcare expenditures as a percentage of GDP, 8.9% in 1980, projected to be almost 20% as of 2027. So where we've really grappled is not just in terms of expanding coverage to more Americans, but we've also grappled in terms of trying to keep a lid on costs and trying to find a way to reduce healthcare costs. One of the healthcare costs that is increasing faster than other healthcare costs is the price of prescription drugs. And we know that pharmaceutical medication, those costs are increasing at an even higher exponential rate than general healthcare costs. This cost increase is not projected to go down, it's projected to accelerate. So the question becomes, how do we do it? How do we try and control some of these rising drug costs? One of the things that Congress and the Biden administration have been talking about is something we've talked about for years, and that's allowing Medicare to negotiate drug prices with pharmaceutical companies. So rather than just saying the pharmaceutical company sets its drug price and Medicare pays it, now you have Medicare negotiating with pharmaceutical companies to try and get the best price. So, allowing the market to lower the prices. So you compare 3 different pharmaceutical manufacturers that create very similar drugs. You then kind of get them into a bidding war and negotiate with them, and you find the lowest price you can get, and that's the price that Medicare will then pay. You've probably seen some commercials that are being run recently by pharmaceutical companies saying that if you allow this to happen, you're going to have rationing of drugs and that people will no longer be able to get their medication. And so it's become a very, very politically charged issue with lobbyists on both sides running commercials and spending a lot of money in order to try and carry the day. Also, healthcare has become very expensive in rural areas as well, because we've really seen a rationing of care in rural areas. It's become more and more difficult to get primary care physicians to work in rural areas. And so when you only have one game in town, you only have one doctor serving, 300 to 500 mile radius, number one, you're not going to have enough access to healthcare. And number two, you're really going to struggle in terms of controlling costs because you don't have any market competition when you only have one physician for that wide of an area. So that's another reason why costs have been increasing. States have taken a lot of steps to try and control healthcare costs. One of the major things we've seen is what we call multi-state legal action, where we have seen the attorneys general in a variety of states join together in lawsuits against pharmaceutical manufacturers and against the big drug companies. And they have highlighted certain drugs that have very high price tags. And so there are some drugs that cost, $1,000 up to $10,000 per month for patients to purchase. And so what we've seen these attorneys general do is join together in multi-state legal action in kind of an antitrust type of an approach to sue these drug manufacturers to try and lower these costs, making the argument that the drug manufacturers are colluding with each other to keep the prices high. Well, obviously, the response of drug manufacturers, whenever you try and control those costs and reduce drug costs, is that they need those high price tags to then fund their research. And we had said earlier on that one of the major positive aspects of our healthcare system is research and the number of research centers. And it tends to be, the US creates a lot of these new medications. And so drug manufacturers will argue they need to charge these prices so that they have the revenue necessary to continue with their research and to continue creating these new medications. And so that's kind of the pushback that we tend to get when we try and control drug prices. Another trend that I think we're going to continue to see in healthcare policy is more of a reliance upon managed care organizations. So managed care organizations, there are 2 primary categories. We'll skip to that. There are HMOs and PPOs. And I don't know if you have an HMO or a PPO, but there's a difference between the two. Health maintenance organizations or HMOs differ from PPOs in that there's less choice with your doctor with an HMO. So the way in which a health maintenance organization keeps costs down is by keeping a smaller list, if you will, of approved physicians. And so you need to then select your physician from that smaller list. By keeping that smaller list, you can then make sure that people only have a certain number of physicians they can choose from, and that will help you control your costs, because then the HMO can then dictate reimbursement rates to that small list of physicians. PPOs provide patients with a lot more flexibility. in selecting which physicians they want to go see. That's why PPO programs seem to be a little bit pricier than an HMO. So if you have employer-sponsored healthcare, it's probably being provided through either an HMO or through a PPO. And usually the PPO price to you as the employer will be a lot higher than the price you pay monthly for HMO coverage. But it's really these managed care organizations that do a lot of the administrative work when it comes to healthcare here in the US. I think you're going to continue to see that in the future as well. Well, how can we really get a handle on healthcare costs? Sure, HMOs and PPOs can help. Certainly getting pharmaceutical companies to play the game with us, that can help reduce some costs. But how can we really reduce costs? One way you can really reduce costs is by passing the cost on to consumers. And now this is sometimes not a great thing to do in terms of maintaining the health of Americans, but you kind of let the market guide you in reducing costs. So if you pass more cost on to the patients, the idea from an economic perspective is that patient will then demand less in the way of healthcare. As long as healthcare they see it as being cost-free, they're going to demand a lot of healthcare and expect a lot of healthcare services. But once you start assigning a cost to it, then your patients will do a cost-benefit analysis. And as the cost increases, then the benefit cost ratio doesn't look as good. And so they're going to then consume less in healthcare resources. The problem with that, obviously, is if they're consuming less in healthcare resources, they may not be taking care of chronic diseases. They may not be doing the types of follow-ups that they need to do in terms of cancer checks and things such as that. Another way that you can potentially control healthcare costs, and this is something that's more from the conservative ideology, is the use of personal health accounts. And so you allow people to set up their own personal health accounts, and then money goes into those personal health accounts, and then people manage that money kind of the way they would manage their bank account. And so they kind of see how much healthcare really costs. And so they might end up rationing some of their expenditures. Focusing more on chronic diseases is another way to control costs, because the more we can target chronic diseases early on in the course of the disease, obviously the less expensive it'll become to treat it later on in the course of that disease. And then obviously focusing more on preventive care. The more we focus on preventive care, well baby checks and wellness checks, cancer screenings, catch problems early, the less expensive they are then to treat those problems. But again, doing all these things kind of require a change in our paradigm and a change in the way in which we've historically viewed the provision of healthcare. Quality of care is another concern. And we've had more and more patients complaining about the quality of the healthcare that they are receiving. They complain that physicians are using expensive procedures when they're not necessary, and they use those expensive procedures so they can bill more. A procedure may not be 100% required, but they'll do it because they can get a higher reimbursement from Medicare or Medicaid or from the HMO for doing that type of a procedure. We've also seen a time crunch where physicians are spending less time with patients. The problem here is that if you want physicians, you have a limited number of physicians and almost an unlimited number of patients. So if you want physicians to spend more time with patients, it means they're probably going to be able to see fewer patients. But what does that mean? That means that patients have more wait time between being able to see their physician. And so in the past, they may have been able to get an appointment within 2 weeks. Now that the physician is scheduling 20 to 30-minute appointments as opposed to 5 to 10-minute appointments, you may not be able to see your physician for 3 to 4 months in the future. So there's always an externality with any of these potential reforms. We've also noticed an uptick in terms of the number of medical errors in our healthcare system. The National Academy of Medicine reports that annually, anywhere between 44,000 and 98,000 Americans die from medical errors. There are also a lot of reasonably preventable conditions that occur from, for example, hospital stays. In the past year, over 700,000 Americans acquired infections from their hospital stays. So there's quality of care issues, there's coverage issues, there's rising cost issues. There are a lot of problems, certainly, in our healthcare system. The problem for us in formulating an effective policy to deal with all these issues is that it has become a very political type of issue. We know that we have this balkanization, if you will, in Congress between liberals and conservatives. And so conservatives are always trying to take down Affordable Care Act. Liberals are always trying to protect the Affordable Care Act. Conservatives advocate things such as vouchers and market competition. Liberals advocate additional coverage and additional spending. And so you've got two completely different approaches coming from two ideological extremes, which has made it very difficult for us to kind of move past the major innovations we got in the Obama administration with the Affordable Care Act. The Affordable Care Act has gone before the Supreme Court on multiple occasions to test its constitutionality. And one of the most famous cases was the Sebelius case from a few years ago. And the Sebelius case, the Affordable Care Act was challenged as being unconstitutional. And the one aspect, there are a few aspects that were challenged, but one of the major aspects that was challenged was what's called the individual mandate. The Affordable Care Act, in order to expand coverage, needed to have some compulsory element to it that would compel people to be covered, to actually proactively go out there, join one of these exchanges, go onto the website and sign up for coverage. Well, the compulsory element of the Affordable Care Act was the individual mandate, whereby every year when you file your federal income taxes, you would have to demonstrate that you had health coverage. If you didn't have health coverage, then you would have to pay a penalty when you paid your federal income taxes. In the Sebelius case, that individual mandate provision was challenged. It was challenged as being unconstitutional. The Supreme Court, in a decision written by Chief Justice Roberts, argued that the Affordable Care Act was constitutional and the individual mandate was constitutional because the individual mandate was not a penalty, but it was rather a tax. And since the Supreme Court saw this individual mandate as being a tax, that falls within the taxing power of Congress. And the 16th Amendment that was ratified in 1913 gives Congress the ability to levy taxation on any source whatsoever without apportionment, meaning that Congress basically has blanket taxing authority. And so Roberts argued this individual mandate is part of Congress's blanket taxing authority. Therefore, the Affordable Care Act is constitutional. Well, despite that, a couple of years later in the Trump administration, Republican-controlled Congress was able to strike down the individual mandate legislatively. And so they got rid of it legislatively when they weren't able to get rid of it judicially. So the individual mandate politically was eliminated through the legislative process. But other than challenging the Affordable Care Act, Congress has really struggled to build upon it. And again, a lot of the reasons why we've had those struggles is because it's become such a politically charged type of issue. That's basically an overview, tip of the iceberg kind of view of healthcare policy in this country. Again, very political. We have, vested stakeholders on both sides of the ideological spectrum. We also have vested stakeholders in terms of consumer rights groups, pharmaceutical companies, American Medical Association, lawyers of the American Bar Association, the National Governors Association, National Conference of State Legislatures, and so on and so on. So it's kind of a microcosm of why we struggle today to make major changes to our policy approaches. But I just want to kind of present healthcare policy because it is such a timely and such a hot button issue as a different policy area that we handle differently than what we talked about last time with education and economic policy. And we deal with healthcare policy much differently, obviously, than we also deal with other policy areas such as welfare policy. So in the second part of class tonight, I thought we'd turn our attention to welfare policy, talk about Social Security and means-tested income support programs, and talk about where those policies came from, who's involved in those policies, and why we have the current policy approaches that we currently have in those policy areas. But seeing that it is 8 o'clock, we've been going for an hour now. Let's say we'll take about a 10-minute break. So come on back at 8:10. And we come back at 8:10, we'll do our discussion of Social Security and welfare policy, and then we'll move into our 4 presentations for the evening, and then we will call it a night. So take a break until 8:10, come on back, and we'll talk welfare policy. Okay, welcome back, everyone. Hope you had a good, although quick break. Let's spend a few minutes talking about welfare and Social Security policy. And I'm not going to spend a lot of time on this, but again, this will be our last policy area that we'll talk about, and then we'll move into our 4 presentations for the evening. So in our discussion of Social Security and welfare policy, we're gonna break it up into those 2 topics. And so we'll talk about Social Security, and then we'll talk about more means-tested policies such as welfare and income support. But before we get into a discussion of Social Security and welfare policy, it's important to talk about the purpose, especially of welfare policies. What are we trying to achieve with these welfare policies? Well, obviously, since they are primarily income support types of programs, what we're trying to do is we're trying to address the issue of poverty. And poverty has a quantitative definition here in welfare policy. And here in this country, the federal government establishes the poverty level as $25,100. And so if there's a family of 4 that has an income level below $25,100 annually, then we say that household is living in poverty. There's also this concept known as deep poverty. Deep poverty is when the household income is less than 1/2 of the federal poverty level. And so if you have a household that's making less than $12,050 per year, then $12,550 per year, then we would say that family, that household is living in deep poverty. And unfortunately, 6% of American households are currently living in deep poverty types of circumstances. So poverty is certainly an issue. And that's the primary goal of these means-tested programs, is to try and address this problem with poverty. So the question then is, where does this come from? And it comes from a lot of income inequality. There's a statistic in poverty studies called the Gini coefficient. I don't know whether you've heard of this or not before, but the Gini coefficient measures the amount of income inequality in a nation. And there's a scale that runs from 0 to 100. 100 would indicate the most income inequality possible. A 0 would basically measure a lack of income inequality, the very equal distribution of income. So clearly for the issues of income inequality, it's better to be closer to 0 than it is to be closer to 100 on the Gini coefficient. When you look at countries across the world, you'll see that on the scale of 0 to 100, typically the country that has the most income inequality is South Africa. And South Africa has a coefficient of 63 out of 100. And that's the highest coefficient that we currently see across the world. The nation with the lowest Gini coefficient is Ukraine, and Ukraine scores a 25 out of 100. So Ukraine has the most income equality with nations compared across the world. The US has a score of 41.5, which puts it number 51 overall in income inequality. So we essentially are in the top half of income inequality for the nations measured around the world. So income inequality is certainly a problem here in the US, Not as much of a problem as in South Africa, but certainly more of a problem than in countries like Ukraine. Just to underscore this idea of income inequality and its contribution to the existence of poverty in the US, take a look at this table. So on table 9.1, what you'll see is you'll see income strata broken down into 5 quintiles. So 5 different strata levels of 20% each. And so the lowest 20%, the next 20%, the third 20%, the fourth 20%, and then the highest 20% of income earners in the US. Then you look at the percentage of income earned by each one of those different quintiles. So the lowest 20% of income earners in the US earn 3.1% of the total income earned in the entire country. The second quintile, the second 20%, earned 8.2% of income. The third earned 14.3%, the fourth earned 23%. What's really striking is when you get to the top 20%, the top quintile, 51.5% of income earned is earned by the top 20% of income earners in this country. So to put it another way, the majority of income belongs to the top 20% of wage earners. And I didn't put this other chart up, but if you break it down even more, you'll see that the overwhelming percentage of wealth is concentrated within the hands of about 1 to 2% of the wealthiest Americans. So clearly there is income inequality, and that income inequality then leads to this problem of poverty. Now, the problem of poverty is defined differently depending upon your ideological perspective. Conservatives will identify poverty and define it differently than liberals will. For conservatives, they will identify the primary problem with poverty as being a lack of opportunity. That's a matter of providing these folks with opportunity in order to remedy their income situation. Liberals oftentimes look at poverty more as an issue of distribution, that we need to more equally distribute wealth and resources across all strata of Americans, across the entire income strata of Americans. So when you define the problem differently, we know you're going to have different solutions to the problem, because the definition of the problem, as we know from our previous discussions in this class, will dictate how you then solve the problem, what you consider to be the most appropriate solution to the problem. So if you identify the problem as opportunity versus identifying it as distribution of wealth, you're going to have a much different solution to the problem of poverty. So let's talk about some of the programs that are in place to try and deal with this issue of poverty. We'll start with Social Security, because Social Security is a little bit different than a lot of our other welfare programs. A lot of our other welfare programs are means-tested programs, meaning that you qualify for benefits based upon your means, based upon your income level. Social Security is a little bit different. Social Security, a lot of people think about it as being a social insurance program. You know, it's by far one of the largest federal government programs that we currently have. A lot of people think about it as social insurance. They think about, well, I work, and when I work, money is taken out of my check that then goes into a trust fund with my name on it, so that when I retire, my retirement will then come from that trust fund of money that I've earned over the years. That's the perception, but as we all know, that's not the way Social Security actually works. Social Security, like a means-tested welfare program, is redistributive in nature. We've talked throughout this class about your 3 main types of policies: distributive, redistributive, and regulatory. Social Security, despite what a lot of people think, is a redistributive type of program, redistributive type of policy. It's a pay-as-you-go type of approach, in that the benefits that current retirees are earning, those benefits are coming from the wages that are currently being earned by people who are in the workforce. So people who are working today are paying for the retirement benefits of people who've already retired. Those people are working today. When they retire, their benefits will be paid by people who are in the workforce at that current point in time. So it very much is a redistributive type of an approach. Social Security is our largest single entitlement program. And we've talked in the past about entitlement programs. An entitlement program is a program whereby you get the benefits because you are legally entitled. You have met some criteria in order to legally entitle you to those benefits. Entitlement programs, as we had talked about in the previous class, they fall in a type of spending known as mandatory spending, because Congress does not have direct control over changing the amount of money being spent on an entitlement program. The only way you can change the amount of money you are spending on an entitlement program is by changing the eligibility requirements. So we might have to, if you want to change the amount we're spending on Social Security and lower what we spend on Social Security benefits, we would have to increase the retirement age. By increasing the mandatory retirement age, we are then making fewer people eligible and fewer people entitled to those Social Security benefits. For Social Security retirement benefits, to earn those benefits, you need to be vested in the Social Security system. And the way in which you become vested is every year of full-time employment, you earn 4 credits toward your Social Security vesting. In order to be fully vested in Social Security, you need to have at least 40 credits earned. So you need to have at least, that translates into 10 years of full-time employment where you're paying into Social Security in order to be fully vested into Social Security. That's for the retirement portion of Social Security. But there are other types of Social Security benefits as well. There's what are called Social Security disability benefits. So if you become disabled and you cannot work, you can then be eligible and entitled to Social Security disability payments. There are also Social Security family payments. And so these are payments that would go to the children of a Social Security recipient. And so, for instance, a Social Security recipient passes away, but they have a minor dependent child. That minor dependent child will then draw Social Security family benefits up until the point in time in which they age out at the age of 18. My father passed away when I was a minor, and so until I was 18, I actually got a monthly family benefit payment from Social Security. It was small, it was like $50 a month or something like that, but that's a family benefit. Then there are also survivor benefits. And so the surviving spouse of someone who is drawing Social Security can then draw survivor benefits. That's important because if you have the person who passed away who is more fully vested in Social Security than the spouse. So if the spouse was a stay-at-home parent and was not fully vested in the Social Security, but their spouse passes away who was fully vested, then that spouse can earn Social Security benefits at the level of their deceased partner. And so they can get more benefits than they would normally get themselves. Then we also have what's called the Supplemental Security Income Benefits Program. This is not true Social Security because this is not paid out through Social Security trust funds. This is paid out through general revenue. So this comes from general fund revenue. It is designed for low-income individuals who are at least 65 years old or who are disabled. That's what's called a Supplemental Security Income Benefits Program. One of the problems we run into philosophically with Social Security is that Social Security is designed to try and give people benefits based upon what they put into the system. But at the same time, it's also designed to try and keep people out of poverty. So it's designed to try and ensure that lower income individuals get a minimum base level of financial protection. So you want to give people benefits based upon what they put into the system, but you also want to try and maintain a minimum level of financial protection for other individuals, irrespective of what they have put into the system. So it's kind of a hypocritical type of approach sometimes with Social Security. We're trying to achieve 2 different goals with the same type of program. The way in which Social Security works is Social Security, as you probably know, is financed through payroll deductions. And when you look at your check, you'll know you'll have some payroll taxes that come out of your check. For instance, you will have your income taxes for federal and state income taxes, but then you also have payroll deductions. Payroll deductions for things like Social Security. So the current payroll deduction rate for Social Security is 6.2%. So 6.2% of your income up to $142,800 will be taken out for Social Security benefits. So you'll get taxed 6.2% up to $142,800 of income earned. Next year, that goes up to $147,000. And every year we increase that amount. So more and more income is subject to those Social Security taxes to try and keep the system as solvent as possible. So you'll see every year that goes up. That's a process known as indexation, where every year we increase that amount. In addition to that 6.2% that comes out for Social Security, there's also a payroll deduction for Medicare, and that's a 1.45% tax that comes out for Medicare as well. If you work multiple jobs, if you have more than one job, there's a chance that you may have excess Social Security tax paid, because each of your employers will take out 6.2% for your first $142,000 of income, not knowing what your other employers are doing. And so you may actually get a credit at the end of the year for any Social Security taxes that have been overpaid. Social Security really is what we call the third rail politically of American politics, in that it's a very difficult policy to touch. It's a very difficult thing to change, because people have become very reliant upon Social Security. It's that financial safety net that people have come to count on. People feel that they have paid into it, and so therefore they should get benefits out of it when they do retire. And so it makes any potential changes to Social Security very, very controversial. But the problem is Social Security is becoming insolvent very, very quickly. And as we'll see in a future slide, projections show us that by the 2030s, Social Security Trust Fund will probably become insolvent. And one of the reasons for that is because of the increase in eligibility. More and more people are living longer lives, and so their retirement years are sometimes doubling. And so we have people who would normally retire at 67 and live to be 77 and draw Social Security for 10 years are now living to be 87 or 97 and drawing Social Security for 20 or 30 years. So that's a big problem for Social Security, because again, that's what drives it into insolvency. So how do you deal with that? Well, one way to deal with that is to increase the retirement age. And we've already done that. We've increased the retirement age gradually from 65 years old to 67 years old. And we're now in the process of increasing it from 67 years old up to 70 years old. In the past, you could apply for Social Security and get full benefits at 62. Then it was increased to 65 to get full benefits. Then it was increased to 67 to get full benefits. And in the future, we're increasing it now to 70 years old in order to get those full benefits. Again, that's a controversial thing to do, but that's what's being done to try and keep the Social Security Trust Fund as solvent for as long as possible. There's also a concern for gender equality, because as we know, women tend to make more than men in the same jobs. And so if you have women who are making 75 cents on the dollar to what a man makes, that's going to affect their Social Security benefits when they retire, because they are less vested in Social Security than a male may be doing the same job. And so you have that type of gender inequality that we have to deal with Social Security. So if we feel confident that Social Security is probably going to end up becoming insolvent by the year 2033, we probably need to do things other than just increasing the retirement age. That's one way to try and resolve the problem. Another thing we can do is we can change what's called the COLAs. You're probably familiar with these. A COLA is a cost of living adjustment. And so every year we will apply a cost of living adjustment to the benefits that recipients receive. And that's to try and keep up with inflation. And so you have goods become 2% more costly next year, then in theory, your benefits should go up by 2% to try and compensate for that increase in prices. We could dial back COLAs, and we could either reduce the amount of cost of living adjustment that retirees get every year. We could eliminate COLAs. Those are ways to try and make Social Security a little bit more solvent. And then privatization. And there have been a lot of calls for many years from members of Congress to privatize Social Security. So how would a privatization of Social Security look? Whenever people call for a privatization of Social Security, they're basically saying we should allow people to have the flexibility to invest a portion of their Social Security benefits, their Social Security money, in the stock market. So maybe not invest all of it in the stock market, but allow them to invest up to 30 or 40 or 50% in the stock market on their own. So they can decide how they want to invest that money, hopefully to get a bigger return on that money than you would just normally get by not investing it. And the positive of that, obviously, is that it could help the Social Security Trust Fund become more solvent. The negative is a clear one, in that it makes Social Security funds much more fragile. Because as you know, the stock market goes up and down. And if there's a crash in the stock market, if you have a 401k, you probably know what that's done to the value of your 401k. Well, that would be an impact that you would then have on your Social Security benefits if you've invested Social Security benefits into the stock market as well. So there are positives and negatives about privatization through investment in the stock market. We tend to not make a whole lot of changes to Social Security outside of tinkering with the retirement age because it's so politically controversial. And the old adage in Congress is, if you go into Congress to change Social Security, you're going to be leaving Congress very, very quickly. And a lot of people have to put it one way, died on the sword of trying to change and trying to modify Social Security. But Social Security is a major issue, because if we have insolvency of Social Security by 2033, you're going to have a lot of people who put money into the program who are expecting to get money out of the program. And if that's what they've based their retirement upon, is this expectation of money from Social Security, it's going to be a very big problem for a lot of Americans. But again, we've been saying the sky's been falling about Social Security for many years now. And our first projections were that Social Security would be insolvent by the 1970s, and then it was by the 1990s, and then it was by 2010. And it seems like we keep pushing it out into the future. Now it's 2033. Maybe, hopefully, with some of the changes to the retirement age, they'll be able to push it out maybe to the 2050s, and so on and so on. But I think there's a good chance that 40 years, 50 years from now, Social Security will still be around, because it is just that much of a third rail of American politics. But Social Security really is based upon, again, investing in the system. And so you're putting money into the system, even though you're drawing out a lot more than you put in, it's still based upon you being vested in the system. Welfare programs are different, in that welfare programs typically are purely means-tested programs. And a means-tested program, as you know, is that we provide these benefits to individuals based upon their abilities, based upon their means, usually as measured by their income level. So if you're below a certain income eligibility level, you are then legally entitled to the benefits from these welfare types of programs. So that's really what differentiates it from Social Security. But the similarity is that it also is very much a redistributive type of program, just like Social Security is a redistributive program. Now, some of the programs, welfare programs that we have in place, you're probably familiar again with a lot of these. SNAP, the Supplemental Nutrition Assistance Program, here in California, we call it CalFresh, but it's a provision of food stamps, it's a provision of these electronic debit cards that people can then take and use to purchase food. It's provided to eligible recipients, usually requires some type of element of either registering for work or registering to look for work and seek out work, but it provides that federal assistance and state assistance for food. Then we also have what was called AFDC, Assistance to Families with Dependent Children. Here in California, we talk about CalWorks, which is the state equivalent. AFDC was originally designed to try and provide cash grants of money to children who did not have parents. Now, over the years, it's been expanded. So now it doesn't just go to children without parents, but it can go to children or families where the parent is unemployed or underemployed. And so we've really expanded the pool of eligible recipients when it came to AFDC. One of the major problems that detractors of the program had is that they would argue that it was a self-fulfilling prophecy, that was a self-perpetuating program, that you would end up with generations of the same family becoming reliant upon AFDC benefits. Another program that we have that's built into the income tax system is what's called the Earned Income Tax Credit, or the EITC. This is another social welfare program that is built into your federal income taxes. The EITC is there for what economists would call working poor. So people who are engaged in employment, they are working, they are employed, but they are making a small income. So, they fall below that poverty level or right around that poverty level. This is a credit you can take on your federal income taxes. And as a credit, it's a very powerful tool because in income taxes, you've got deductions and credits. Deductions are ways in which you can reduce your income prior to calculating your tax liability. So if you reduce your income level, then you're by definition going to pay less in taxes because you'll fall into a lower income tax bracket. So they're powerful, deductions are powerful tools, but they're not nearly as powerful as a credit. A tax credit comes off of your direct tax liability. So you go through your taxes, you calculate your income, you multiply it times your tax percentage, and you get the tax liability, the amount of taxation that you owe to the federal government. So if you owe, say, $2,000 to the federal government, then you subtract your earned income tax credit. And so if you have a $3,000 earned income tax credit, that $2,000 liability has now turned into a $1,000 credit, and you're now getting a return on your taxes of $1,000. So a $3,000 tax credit is a lot more powerful than a $3,000 deduction. Let's say you have a $20,000 income. If you have a $3,000 deduction, that lowers your income to $17,000, which you still have to pay taxes on. So you multiply that times your tax rate of 10% or 12%, and then that's the amount that you would owe. With a credit, you can completely wipe out your tax liability if the credit is large enough. One of the problems that we've run into with the earned income tax credit, we continue to expand it, and we continue to make it available to people at higher and higher income levels, because it has been a good tool to help pull people out of poverty, especially pull people out of deep poverty. But there are a couple problems. One problem with it is fraud and abuse. And it has become a red flag for the IRS. And so when you file your income taxes, if you claim the earned income tax credit, that will immediately cause the IRS to look closer at your tax return. And you go into a different category of tax returns where they will scrutinize your tax return much more closely to make sure you truly qualify for the earned income tax credit. Because there have been a lot of instances of people who make six-figure salaries who still go and claim the earned income tax credit, even though they are not eligible for it. So it does somewhat raise your potential for being audited. But the bigger concern is obviously a budgetary concern, because the more you expand the earned income tax credit, the less taxes people are paying, the less taxes people pay, the less revenue coming into federal government coffers, which means the less money the federal government has to then pay for additional programs and policies in the future. In the 1990s, we had a major welfare reform initiative known as the Personal Responsibility and Work Opportunity Reconciliation Act. And that's what that PRWORA stands for on the screen. Personal Responsibility and Work Opportunity Reconciliation Act. Essentially what we had in the 1990s is we had a Republican Congress and we had a Democratic president. But the Republicans in Congress and the Democratic president were able to come to a somewhat agreed upon definition of what some of the problems were with current welfare policies and programs such as AFDC. So what we ended up with the welfare reform in the 1990s is we created a new program known as Temporary Assistance to Needy Families. So we created these new grant programs, TANF grants, Temporary Assistance to Needy Family grants, that then replaced the lion's share of AFDC grants that had been in place before. TANF grants were considered to be block grants. And a block grant is a general grant of money whereby the recipient can spend it kind of how they see fit, as long as how they're spending the money helps fulfill the goals of the program. So in this respect, the TANF grants were provided to state governments, and state governments could then use those TANF grants on different types of programs. They could use it on child care programs or education programs, after school enrichment programs. They could spend it how they wanted, as long as how they were spending it helped move people from welfare to work. And the big requirement under the welfare reform in 1990s was states had to document how effectively they were moving people off of welfare support and into the workforce. And that's what these grants were meant to do. They impose work requirements in a period of time whereby the person needed to find gainful employment. Now, the way in which those TANF grants worked is they were relatively successful, especially early on in many states, because of a quickly growing economy. If you think about this welfare reform that went into effect in 1996, throughout the late 1990s, we had the internet boom. And we talked about this when we talked about economic policy. The internet.com boom and this great boom in business in the Silicon Valley led to the creation of all these new startup companies and led to the creation of all these new jobs. We had an explosion in the oil industry in states like North Dakota and South Dakota and Alaska and Montana and Wyoming. So we had all these new jobs that were opening up. Because of all these new positions that were being created, it became relatively easy for states to move people from welfare to work. And so they were able to meet these work requirements relatively easily under this welfare reform law. The problem is some other states had more difficulty in doing it. So if you look at a state like North Dakota in the 1990s, and even today, they have this booming oil industry. And so what they have been doing is they've been recruiting people from out of state to come to North Dakota. And they're providing, not only you'll get a job, we'll provide you with housing, we'll give you all these great credits, because they needed people to come to North Dakota to do work in the oil industry. Well, because they had so many jobs, if you look at the percentage of people move from welfare to work in North Dakota, it was like 75 or 80% of people got jobs in North Dakota. You compare that to Alabama or Missouri or Iowa or any of those other states where job growth was much slower, they were much less successful at abiding by the requirements of the Welfare Reform Act. But it was all premised upon this idea of moving people from welfare to work. Whenever we try and reform welfare, there are always concerns. One concern with reforming welfare is that it's a money trap. And you'll hear conservatives in Congress talk about this all the time. We're throwing good money after bad. That we are spending money on these programs. Throwing money at a problem does not solve that problem. From the other side of the spectrum, you'll hear concerns about how we're not redistributing wealth well enough, and that we need to lower the income levels to make sure that welfare programs are really only benefiting those at lower income levels. You'll hear some complain about the requirements that are attached to welfare reform that kind of creates what we call a new paternalism, in that by linking up these welfare benefits with these goals, we are basically holding people accountable for achieving goals set by the federal government. And so it kind of becomes this new paternalism where it's really the federal government that is caring for people and telling people what to do and how to live their lives. And so it kind of imposes government values upon personal values when we require work for welfare benefits. The Welfare Reform Law, the Personal Responsibility and Work Opportunity Reconciliation Act, was really based around four main goals. The first goal was to enforce work requirements, again, to move people from welfare to work. In moving people from welfare to work, it then helped to achieve the second goal, which was to reduce dependency on federal aid. So people can become more independent and not be dependent upon money from the federal government. Third, it promoted marriage, and that it provided additional benefits and greater access to benefits once someone was married as opposed to being a single parent. And its fourth goal was to try and reduce poverty, to try and get people out of poverty, and especially get people out of deep poverty. How well did welfare reform work? Well, we did see a pronounced reduction in welfare rolls throughout the late 1990s and into the early 2000s. But then in the 2000s, we had another financial entrenchment, and we saw this time of financial crisis again. We saw higher unemployment rates. We saw people losing their jobs, fewer jobs available. Welfare reform then became less successful. Welfare reform, as it was created in the 1990s, is directly tied to economic policy and directly tied to economic conditions. When economic conditions are good, welfare reform, as conceived in the 1990s, tended to work very well. When economic conditions are poor, welfare reform did not tend to work. And so it's kind of this tethering of the two together that we learned was very, very important. And unless we could have effective economic policy, our reform welfare policy typically would simply not work. So we do have a much different approach to welfare after 1996 than what we had in the old days of AFTC. Much more of an emphasis on moving people from welfare to work. And again, that's difficult to do when you have times of economic downturns, especially now, like we're looking at as we sit here in the second half, hopefully, of a pandemic. You know, who knows when it'll end, but hopefully, optimistically, the second half of the pandemic, there are some fewer jobs out there for folks. People are sometimes having trouble finding those jobs, and so the need for welfare support then increases. We saw that increase in terms of stimulus payments that were being made by the federal government as well as being made by state governments. We saw this acceleration of the child care tax payments that were going out as well, so that now you have a front loading of a lot of these child benefits to families who have children. When they go to file their taxes, those benefits are then going to be exhausted. And so what they would normally be able to claim as a child tax credit has already been prepaid to them. So it'd be interesting to see what happens in terms of economic growth once people realize that those stimulus monies are gone. So we saw a lot of these welfare-oriented, means-tested types of programs throughout the pandemic, both at the federal level as well as the state level. So we're kind of in a new era now of welfare policy. We'll see what happens post-pandemic. If we return then to our 1996 types of approaches, if we return to pre-1996 approaches, or how long our current economic stimulus approaches will last in terms of trying to move people from poverty up in upper income social strata. But again, you really can't have success in welfare reform unless you have a successful economic policy approach. There are a lot of other areas of policy that if we had time, we could get into. We could get into more of housing policy. We could get into more of environmental policy. I know some folks are very interested in both housing as well as environmental policy. Unfortunately, in the contracted schedule that we have in this class, we just don't have the time to get into those policy areas. So I apologize for that, but hopefully you'll be able to get some elements of housing and environmental policy in other courses as you move your way through the MPA program. You also then have the opportunity if you're interested in environmental policy that we're not able to cover in this class. There's an environmental sciences major on campus, and they have a graduate program, and so you might be able to look into some of those environmental courses over in environmental sciences as well. So We'll call it quits there for our discussion of our policy areas for this evening, because I do want to leave some time. We're pushing 9 o'clock, so leave some time for our presentations. So let me go ahead and stop my share. For our presentation tonight, like I said, I'm very grateful. We have 4 folks who stepped up and volunteered. Anna, Elena, Adderley, and Connie all volunteered to go tonight. So I hope that's still good with all of y'all. If so, we'll start with Anna with the presentation tonight. And Anna, I'll turn it over to you. If you want to share slides, you can. If not, that's fine as well.
Okay. All right. Sounds good. I'm going to, I have a PowerPoint, so I will try sharing that. Okay. Okay. Can you guys see the screen?
Yep, looks perfect.
Okay. So my name's Anna, and the societal problem that I had chosen for my presentation is on, or my paper for this class is food insecurity in Los Angeles County. So just kind of like a brief summary. So USC Food Insecurity actually did a study. Part of my research was pandemic and also kind of geared towards post-pandemic food insecurity. But as of during the pandemic, more than 1 in 4 LA County households couldn't access nutritious food at least once between April and July of 2020 last year. And then due to the pandemic, food insecurity did increase by 42% in July. And this is compared to pre-pandemic numbers, which was at least 27% for low-income households. And then some other issues that were related to food insecurity is due to the high cost of living. People are often having to face hardships of whether they can afford, grocery bills or their rent and utilities. And then another association with food insecurity is something that's kind of like food swamps, which are the concept of urban areas that have a densely populated area of fast food chains or liquor stores. So they don't have as readily access to grocery stores or other areas that have healthy food options. So one alternative I had was the concept of urban farming. So an idea for that solution would be LA County could partner with more NGOs to turn empty lots into community gardens, or there's also areas where there might not be empty lots available. So we would possibly be partnering with schools. So for an example, there's the Garden School Foundation. They actually partner with at least 8 Title I elementary schools in the Los Angeles area at the moment. And they utilize lots on those elementary school spaces to create community gardens for the students to learn garden school curriculum. The community residents and families also have access to it. The LA Community Garden Council is also another NGO that supports 42 community gardens financially. And they also partner with at least over 100 other ones where that's people who want to try to create their own community garden. How do they get a bylaw started? How do they go through grant process? So they also support other community gardens in that aspect. And then out of the 88 cities in LA County, there's actually this chart. It's a larger chart, but I thought this was pretty interesting to see. Let me go to the next slide, where they some cities actually have regulations in place in specific areas for urban agriculture, which I thought was cool. So for example, if you see the city of Long Beach, you could have, beekeeping, you'd be able to do classic fruits and vegetables, farmers markets kind of style. There were a lot of cities that don't have any regulations from the study that you could locate. So that would probably be something where cities could expand on improving their zoning laws and regulations for more urban farming in their cities. Another example is Ron Finley, or I think if some people know him as, he's kind of known as the gangster gardener. So he lives in the South LA area of Los Angeles. Back in 2010, he had started experimenting with those parkways that are in front of your homes. they're technically city-owned land, but you're supposed to, as a homeowner, still keep up with it. So his idea was to turn those little parkways in front of his home into a community garden space, and just grow his own fruits and vegetables, where he actually was fined by the city for doing so. So he ended up fighting against the city with some other green activists, and got the right to grow his own vegetables on the parkway, but that's only within the city of LA, unfortunately, compared to, like, the other 87 cities that are in LA County. And then other ways, is just if the city of or the county of Los Angeles focused more on possibly providing more grants for NGOs, it would help cut the cost of administration expenses. They'd be able to expand more services, and even just expand existing programs like the Los Angeles Community Garden Council of creating more urban farms within these dense areas of cities in LA. My other alternative solution is expanding meal delivery services. So for example, Meals on Wheels and Project Angel Food, they do a lot of meal delivery services to the elderly, chronically ill people, or people who are homebound and can't leave. So meal delivery services dramatically improve the lives of those that can't prepare their own meals or even afford to pay for healthy meals. So this is another thing where it could also lessen food waste, and cut trips to grocery stores for seniors. Offering a regular meal delivery service for those that are deemed food insecure also help drive down medical costs. So for example, I have, okay, so without access to subsidized meal delivery services, some elderly have no choice but to move into a nursing home sooner than they plan. And issues like this can actually cause a strain on California's Medi-Cal program, where they may have to cover the cost of the expenses. So by state and local governments contracting out these types of services, it can increase the efficiency of delivering these types of resources to a larger demographic, and also just improve their quality of life. An example that the state of California did during the pandemic was the Great Plate Delivered program. This actually ended August 10th of last year, but the idea was LA County provided 3 home delivered meals daily to older adults over 60 that were high risk by COVID, according to the CDC. And a lot of this was covered through FEMA, state funding, and also local jurisdictions. So this would be something like, if they were able to possibly expand this type of program, it definitely would be more beneficial, not just during these dire pandemic situations. Another thing that the state of California also did was they enacted free school meals for all as of this year, where every child, no matter of income level, qualifies for breakfast and a lunch meal in school. But some things that they don't participate in, unfortunately, is during those summer and winter breaks, is also doing meal delivery services for students. This year they did, just because of that act that passed, and also just due to the circumstances of the pandemic. But I think moving forward, if they're able to expand that by offering summer and winter programs as well, of offering meals for students, that would also help with this food insecurity issue. And then my third example is expanding market opportunities. So for example, California Freshworks Fund is a fund that helps offer funding to more grocery stores or NGOs that want to improve access for affordable, healthy options. So for example, Northgate Gonzalez Market, they're a pretty well-known chain, at least in my neighborhood, in the South LA area. They actually did a poll with some of their Inglewood residents, and they came back and said, they want to have more healthy, affordable access to food. So part of this was Northgate got funding through the Cal Freshworks program, where they were able to expand another store, open up 30,000 more square feet of retail space. And that helped improve access to all of those residents that live nearby. And it also created more jobs. So like that as an example, other groups that can apply for this are people who are trying to create urban farms. And with that, they could create their own farmers markets. And then a cool thing about some farmers markets are there's farmers markets within the city of Los Angeles that can partner with the CalFresh program. That's called Market Match. And Market Match is essentially people who are recipients for SNAP Fresh, where they could go to participating farmers markets. It's only in the city of LA, where CalFresh will match dollar for dollar up to $10 in vouchers when they spend at a farmer's market that can go towards more fruits and vegetable purchases. And so the solution that I ultimately ended up selecting was expanding more of the meal delivery services, because I felt from what I was researching, I found that Medicare could actually save $1.57 for every dollar spent delivering healthy meals to seniors after they have been hospitalized, because there was a bipartisan policy center study that found that Medicare can do a better job of coordinating delivery meals to chronically ill patients that have just left hospitalizations, because it would help prevent future health flare-ups that would ultimately send them back to the hospital. So if Medicare would spend around a little over $100 million a year just providing meals, it would ultimately help them avoid spending over $150 million in expenses from elderly patients that had flare-ups and had to return to the hospital. So like these types of savings could be greater also if they took this into consideration for preventing also elderly from entering nursing homes sooner as well. And then also by providing meals for seniors at home, this creates access to more healthy food for them, especially people who have diabetes or heart issues. And then it's also beneficial for those that are homebound and don't have the support of family or friends, or possibly don't even have transportation to make grocery store trips for themselves, or just access affordable, healthy food options. And then for students, meal delivery services for low-income students during the winter and summer breaks, just to help close that food insecurity gap. There is a USDA program called Meals for Kids that they do offer a summer meals program, but it's typically pre-pandemic. It would be the students had to actually be dropped off by a parent or guardian, and then it was like a group eating situation. So they would be eating at wherever the location would be. It's most likely a school, and then they would be picked up. However, some students can't access transportation to just go to the school and get those meals. So if it would be also a way where they could expand it and offer those meal deliveries for these types of students, I think that would also be beneficial to help lower that food insecurity. And yeah, that's my presentation.
Great job, Anna. Thank you very much. Are there any questions or observations? Okay, that was absolutely perfect. And I see your slides. I always say I need to up my slide game because my slides they don't compare, but very well done.
Thank you.
Appreciate it. Good job. Okay, Elena, would you like to go next?
Yeah, can you hear me?
Yes, can hear you loud and clear.
Perfect, thank you. I also will share the presentation. So I did my policy paper on the rising costs of public higher education in the United States. And to start off with some background, we all heard about human capital, but sometimes there is no precise definition of what that is. And more articles I read, more definitions I get, but the one common definition is just it's knowledge, skills, experiences that the individual possesses. And usually human capital helps people to advance them. And one way to increase your human capital is through getting more years of education or more schooling. And usually it all ties to the returns to education. We all know that high school graduate earns less than a college graduate. And then if you have master's degree, you earn then more than the one the person who has just undergrad degree. So benefits of higher education. We're all here getting higher education, so it's almost silly to talk about them, but there are some that I didn't even think about. For example, on the macro level, so it's the level of the whole country. Of course, we're getting educated and skilled labor force, and why it's important, because people can make educated decisions on in their citizenship. For example, they're going to vote, and they're going to vote. Doesn't necessarily mean that they're going to vote for party that we think is a good party. It's just they're going to make a conscious decision, and just being good citizens, that's important. I think especially in the United States. Also, there are have been registered lower crime rates in countries that have higher levels of education, greater political stability, that's for sure, higher life satisfaction, and better health outcomes. Of course, higher education, I graduated with an econ degree, and I actually did my final thesis on how years of schooling related to income inequality. Of course, all of those are kind of tied to income inequality. Of course, countries that have more income, or people who have more income and less income inequality, they'll build more life satisfaction and better health outcomes. Of course, education is not the only determinant of the like health outcomes or like life satisfaction, but it's one of those. On micro level, means individual level, it improves an individual skill set and labor market outcomes in terms of better employment opportunities, higher earnings, and upward social mobility. And this is why we go to school. This is why we're all in the MBA degree, because we will be qualified for better jobs that pay much more. So in the last 40 years, there was an increase in college enrollment for private and public institutions, which is good. That means that people are getting more years of schooling. And in 1980, there were 12 million students. And in 2021, that was almost 20 million students enrolled. At the same time, the tuition fees, room and board are also going up. So in 1980, the average for tuition fees, room and board was a little over 10,000, and 38 years later, it's 28,000, and that's our average among all the private and public institutions, and they're in inflation adjusted. So how do people pay for their schooling? And there is where the debts are coming into play. So in 2003, there were 330 billion in student debt, and in 2020 it's an absolute crisis. It's 1.7 trillion dollars of household student debt. So it's good that people are enrolling in the universities. However, the tuition is going up, and people don't always have the opportunity to pay for it, so they have to take student loans. So the research question was for this policy paper: what are the alternative solutions to the rising cost of public higher education in the United States? Just a little information on current government funding. A lot of education is usually the priority of the state and local governments. Mostly the funding comes from the state. And usually the measure of state funding is the funding per full-time equivalent student. So in the last academic year, the average appropriations per full-time equivalent student was 8,600. So it's average in the whole country. So ranging from the lowest 3,300 in Vermont and 21,000, almost 22 in Wyoming. And of course, we know that Wyoming, it's less populated state, so of course it's going to be higher. So it's not a precise measure. However, what was interesting to me is that amount, the dollar amount, is lower than education spending per FTE before the Great Recession. And nationwide, education appropriations are on average 6% below 2008 levels and 14.6% below 2001 levels. So in the last 20 years, we haven't recovered from 2 recessions that we had in the last 20 years. So shift of tuition responsibility, there is a shift of tuition responsibilities to students and families. So what that means is that in 1980, families, students and their families were responsible for only 21% of what they had to pay to go to school. And in 2020, it's 44%. So it's more than 20% increase in 40 years. And that's how we see that the loan debt is increasing. Some of the stakeholders in this whole big mess is, of course, students and their families. They're primary stakeholders because they are the ones who are responsible for paying more money for tuition, room, board, and fees. Higher education institutions, of course, because the problem is they have to balance the financial aid that they give out to students and the revenue that they make, because they, at the end of the day, they still have to invest in the infrastructure. They have to invest in their faculty and staff. So they have to balance those things up. They can't just give out a lot in scholarship and don't pay attention to their own well-being. Student loan agencies, and they're also public and private, because again, if tuition is going up, a lot of students are turning to those student loan agencies, and they are playing a great role. And there are different ones in the way how they operate, on what the interest rate is, when you're paying the interest, and so on and so forth. And the greater society as well, because education is a positive externality. Again, I talked a little bit about being a good citizen just because you're getting education, and that's true. And sometimes we don't really understand how the society benefits from it, because now it's just common that education is common in the United States. But if we look at countries like, I'm from Russia, and not everybody goes to university there, especially in the smaller cities. And the difference between the big city, like I'm from Moscow, for example, and I traveled a lot with my sport team, and I've been to Siberia, for example, and Jesus Christ, I would love to establish a lot of universities there. So, and the difference is enormous between people who actually attend and how they develop the society, and between people who just go straight into labor force, and sometimes they're not healthy choices. Like there is a lot of alcoholism there. So like in the United States, it's way better, and it's a lot of benefits to the greater society. So some solutions that I found in the literature and was just able to come up with, encourage more students to attend community colleges. It has a lot to do with stigma, because original community colleges were for low income minority students who couldn't afford going to four-year colleges. However, in the recent years, the attendance and the enrollment in community colleges increased. The reasons for that is that the community colleges are, people pay much lower there. For example, the average in the United States for the community college is 1 year is $3,300 versus 1 year in a public four-year university is $9,300. So the difference is, there is a big difference, and people are trying to avoid debt as much as possible. And then they decide to transfer to a four-year university. So they're saving up a lot during those 2 years that they go to community college. Also, there is a smoother transition from a high school to a four-year university. It's kind of this in the middle, because it's not a college and it's common sense, but it's also like easier to come out of high school. The reason for that is also lower student-teacher ratio, because usually in community colleges, professors are not obligated to commit a lot of time to their research. So they have more time to spend with students in the classroom. And a lot of professors in the community colleges, they don't have PhD degrees, but they're master's students, and they have a lot of experience in the industry and teaching. So, so there is that trade-off between being taught by a PhD person or having a little bit more relationship with a person with a master's degree, which for some people it works. And of course, general education courses are at much lower cost. So I know that a lot of people go to community college, for example, to just fulfill their GE requirements and then transfer. Sometimes when people transfer degrees, or not transfer degrees, they decide to quit one university and reapply to another. They need to do some general requirements for their major, especially for science. And they prefer to take it in the community college just because it's much cheaper and less stress. So one of the, so how to make those community colleges, how to encourage more students to go to community colleges. The biggest proposal is to make first 2 years of in-state attendance free. And I know that Obama administration did a lot of it as of education promise. So they did a lot work on that. I know that in California, it's free for residents, but not all of the states are following the same footsteps. I know that Biden administration was trying to push the bill through the Congress, but it hasn't been approved yet. And from the recent news, it wouldn't be approved, or the bids are very low. The next alternative is to establish or improve articulation policies. So articulation policies, they have to do with the transferring process. So transferring process becomes very complicated when student transfers from a community college to a four-year university. That happens because there are a lot of not matching degree requirements, even if the major is the same. There is no common course numbering. So students end up taking the same courses twice. The reason why they do it is just because the syllabus sometimes doesn't match, or the universities refuse to look at the syllabus from a community college. And also there is a limited number of credits that institutions, four-year institutions, are willing to accept. So that's another problem, is that, again, students just have to retake the courses that they already mastered, and it doesn't add any value to their education. They just have to spend more money on that. So articulation policies, they arrange, it's kind of like a range of processes and relationships that involve the movement of students from one institution to another within one state, sometimes across states, but that gets complicated, at least within state. And some policies and agreements, they involve common course numbering or equivalency systems. So again, even if it's not the same course, sometimes institutions are willing to look at the syllabus and confirm that, oh yes, that's, even if the number of the course is different, it was just the same material that we teach in another course. Another one is common general education requirements. Again, just to make, for example, for accounting, make the same courses required in the community college, so people can get their associate degree there and transfer to the four-year institution. Another one is statewide standardized core courses, core course sequences for specific majors. That relates to general education requirements. And the last one is transferable credits within state public institutions. So there are proposals about to transfer all the credits. It doesn't matter if it matches the common course, but essentially people already spend time doing or taking the class. So in one way or another, the courses have to transfer. Sometimes maybe not towards the major, but maybe towards the general requirements. Like sometimes people have to take courses in certain divisions. So that would be also helpful. So the best alternative solution, I chose the establish and improve articulation policies. Why? Because this is going to be less costly than providing subsidizing for community colleges. The proposal in Biden administration to make two-year community colleges free nationwide was $45.5 billion. And I think it would end up being much more, because you have to sponsor that program every year. So it's not just 1 year. So it's just gonna be very expensive for the United States if they want to introduce that nationwide. Another one, some states already set some articulation policies. For example, North Carolina and Florida. I know that in Florida, they have common course numbering system. In North Carolina, they have the whole legislation about it. So policymakers don't have to come up with those agreements and policies from scratch. They already have an example, and those examples actually work in those states, so they can just mimic what they're doing, maybe adjust some things and just introduce it nationwide. And free community college programs do not guarantee less debt if there are no transfer and articulation policies and agreements between 2-year and 4-year universities. So even though if there are opportunities for people to go to colleges, to community colleges for free, it doesn't guarantee them less debt if they can't transfer their credits. Because yes, they can go to community colleges for free, but if there are no good articulation policies, they will end up retaking those courses in the 4-year institutions, and then they will still end up with debt. So this is my presentation. Thank you. I'll be happy if there are any questions.
Thank you, Elena. Any questions for Elena? Okay, nicely done. Very good work. Thank you very much. I think next we have Adderley. Are you ready to go?
Yes, give me 1 second. Sorry for that. Okay, can everyone see me?
We can see you. I can't see the presentation though.
There it is.
There you go.
Alrighty, hello everyone. My name is Adderley Pelayo, and my topic is on food insecurity, specifically in low-income communities. So food insecurity is one of the leading health and nutrition issues in the United States. So it is defined as a condition in which households lack of access to adequate food because of limited money or other resources. Now, food insecurity, I feel like that's something that we all kind of know about or have experienced it or witnessed it in a way or another. But when I was doing the research, I came across that my third bullet point, and I thought it was really interesting how California produces about half of the nation's fruits and vegetables, but yet 1 in 5 people struggle with food insecurity. I used to go to school at CI, and it surrounded a lot of farms, and I actually got to meet a lot of my friends that they have their parents working farms, helping growing vegetables and fruits, and they would even tell me themselves that they didn't have access to any of that food, and they would still struggle economically and with the access of food. So I thought that was pretty sad, and that's when I became more of the issue, I guess. Low-income families are more likely to suffer from food insecurity than other families who do not fall under the low socioeconomic status. And poverty is a significant predictor of food insecurity. There is a high rate of food insecurity amongst the poor, but the lack of healthy food is essentially connected to homelessness and health issues, making this a very important issue we're discussing, in my opinion. There is a low intake of vegetables and fruits with the low-income population, leading them to being exposed to an increasing risk of a chronic disease. Okay, so I was under the impression that we were able to pick 2 to 3 solutions. I picked 2, so that's what I'm going to be talking about. One of the solutions or alternatives that I kind of talked about on my paper was the implementation of revised or new policies targeting low-income communities. To me, that's huge and it's important, and I feel like every journal I read talked about that over and over again. And one of the major points that I grasped through the readings was that how it's very important to understand how communities and states face different challenges. And policies should be intended to help increase people's quality of life, not only prioritizing what will increase the country's profits. Not to be clear, I'm not saying that we shouldn't focus on how to enhance our country's profits, because obviously that's needed. But it is important to recognize that populations face different challenges throughout each state and counties that we kind of have to, in a way, separate from everything and take a deeper look in order to find solutions to those problems. We have programs in place to help people obtain food, but the programs are not always easily accessible. For example, people who don't have the means of transportation, like don't have cars, or don't have access to technology. During COVID, as we all know, everything pretty much shut down and a lot of people were unemployed and they didn't really have access to food. A lot of food pantries also closed. So in order for them to ask for help, they pretty much had to go online and request for applications, and a lot of people didn't have those means. Some of the programs that we do have in place is the policies, the Farm Bill and the Child Nutrition Reauthorization Act, which is pretty much to help fight food insecurity, and they pretty much help make updates to current policies and programs to address what people need. Some of the key elements that I kind of talked about on my paper was how policymakers need to identify how food insecurity is affecting people residing in different states, directly and indirectly, to effectively collect information on what type of issues need to be addressed, varying by state. And I do want to include the quote that Dr. Powell included on my paper, because I feel like that really helped summarize what I was kind of talking about, is how the one size fits all approaches do not always work. So the second alternative that I kind of talked about, it kind of overlaps with two, but I kind of put it into one. I briefly kind of talked about how education is huge and important. I feel like it is important to educate people on how what we consume, it affects our bodies, and the importance of living a healthier lifestyle. However, I do believe that education, it is not enough. I feel like finding ways of persuading people to, in a way, be more acknowledge more what they consume is important. And by that, I mean, kind of leads to my third bullet point, and then I'll go back to my second one, is how we see advertising everywhere. When it comes to the fast food industry, we see it on the streets, we see it on our social medias, we kind of see it on the TV, how delicious and cheap the food is, right? And it's easily accessible everywhere you go, everywhere you turn is there, or at least where I live currently. It's not the best part of Long Beach, and in every corner of the street of where I live, there's like 3 places where I find fried chicken. But in order to find like a Trader Joe's or a supermarket, I have to drive about 20 minutes just to get there. So then it gets me thinking, okay, well, what if I didn't have a car? So also I feel like once we start kind of advertising the benefits of healthy foods and the negative effects of unhealthy foods, often on our social medias and TV, we could at least start getting people to acknowledge what they already know, or if they don't know, start educating them in that way. Now the second bullet point, finding ways to restrict fast food restaurants from taking over cities. I was kind of hesitant in including that one because I know it's a little bit of a stretch. I know it's probably really hard to do that, but tying it to the example that I from where I live right now, I think it's kind of crazy in a way to think about how this term, the fast food industry, has been taking control over, our cities. It's easier, it's accessible to get fast food than a quote unquote healthy supermarket. So I do think it's important to at least think about what it could look in the future, finding a way to implement it into a policy or regulation of how many fast food restaurants are allowed to be in specific cities or specific streets. I'm also guessing. But yeah, just because we have programs that enhances the access to food does not always mean that the food is healthy. It is important to remember that having access to food with poor nutrients in it doesn't mean enhancing the whole concept of food security, which I also included the last quote there that says policymakers need to understand that there's a difference between giving access to nourishing foods versus giving people easy access to calories, because what happens when we keep feeding people all these calories, they essentially start getting health issues. especially in our kids, because they start to grow up with all these chronic diseases because we are not reinforcing the whole concept of eating healthier and living a healthier lifestyle. So between these two alternatives, if I had to select one, I think they're both equally as important in a way. But if I had to choose one, I think I would choose implementing revised or new policies that target low-income communities, because I believe that in order to see actual change and future change, we kind of have to start since the very beginning and take a step back and dive deeper on what needs to change in order for us to target specific challenges that people face within different states and cities. I believe someone commented on my post last week, 2 weeks ago, I think it was Valeria actually, that she said that maybe we could start looking into the local level government and see how they could step in and help in implementing new policies, because since they have the more primary knowledge, because within the city, they may be able to see what's better for the community in that sense. So yeah, it was a wrap up and summary of my paper was. So thank you for listening. And if you guys have any questions, I'm happy to answer.
Okay, great. Thank you very much. Any questions? Yeah, and I think you're right. One of the vehicles we have are franchise licenses, and the cities can control the franchise licenses and just not issue franchise licenses to new fast food restaurants. And so there is that type of control that I think could work pretty well. So you're well done.
Okay, so there is. I was able to.
Yeah.
I was trying to find articles, specifically journal, that talked about that, but they all kind of started hinting to that, but then retract and say, but we need further research for us to go there. So that's why I kind of wanted to touch it, but not really make an argument for it, since I don't have the information for it.
Yeah, I think it is possible, but I think there are a lot of political issues with doing it, and there's going to be pushback from corporations, but it is possible that you can limit the number of franchise licenses you're giving out to certain types of restaurants, so they can do that. So very good, thank you. Well
Awesome,
done.
thank you.
Okay, great. Next up, our fourth one is Connie. So Connie, if you're ready to go.
Oh, sounds good. Let me just bring up my slides. All right, great. So hopefully you're seeing this title slide first. Okay,
Yes,
cool.
looks good.
Well, thank you so much for the opportunity to speak tonight and to talk about an issue that's really important to me. So I'll be presenting on the importance of tackling the increase of wildfires related to climate change. According to research completed by the National Institute of Standards and Technology, wildfires are becoming more and more common around the world, and households are frequently advised to evacuate when these fires are in nearby communities. And I think this is an issue that we've all been impacted by in the last couple of years. And so just to give you a little bit more context and background, since 1980, the United States National Oceanic and Atmospheric Administration has reported that an approximately threefold increase in so-called billion-dollar natural disasters across the United States have occurred. And these wildfires are over $1 billion in losses. And so the number has increased from an average of 1.5 events per decade. So looking from 1980 to 1990, it's increased to 7 per decade from 2000 to 2019. So this is costing the country a cumulative of 10 billion to 75 billion over these two time periods. So it's definitely an economic hit that we've encountered in the last couple of years. So let's look a little bit about the societal problem. So I think that in terms of this area, climate change is a huge issue. And so I decided to look at looking at specifically homeowners and communities and what we can do on the individual level. So what we're seeing on the ground level is, due to dry climate, the Western United States has experienced much of the country's wildfire burning. So there's tons of acreage that has been lost. And it's really interesting, they've kind of talked about wildfire history. And in an interview with New York Magazine, there's a fire historian named Stephen Pine. he said, if we think about adding up all the ways we're using fire, we're creating the fire equivalent of an ice age. So it's really interesting, I think, to see this new decade as kind of as a fire age. And he described how the U.S. fire community has developed a national crisis strategy for wildland fire. And so looking at creating fire adaptive communities, creating fire resilient landscapes, and developing a workforce that's capable of implementing these goals. Now let's look at some of the stakeholders that are involved in this issue. So some of the stakeholders that I looked at are those who have been affected by recent wildfires. So that includes homeowners and those especially in vulnerable communities. Researchers at the University of California, Irvine and the University of California, Davis found that certain areas not only sustained 3 times more wildfire on average, but also these areas tended to be characterized by higher rates of poverty, unemployment, vacant housing, as well as higher proportions of low-income residents and residents without college degrees. And so this is a huge concern because these areas that are being affected by wildfire burns, they're also a home for many elderly residents. And so researchers have really recommended and encouraged policymakers and state agencies to really look at this issue and study it more closely to determine how you can really allocate the resources. And another group that we sometimes think about is the business community. And I found it interesting that a report by CoreLogic found that after the Tubbs fire of 2017 in Northern California, many homeowners found that their properties were underinsured and there was hundreds and thousands of dollars. And so it left them with not enough coverage to rebuild their homes. And so it's really important with that thinking to really encourage and have the business community and especially insurers work with homeowners to regularly reevaluate the reconstruction cost values of a home, because there's an increased likelihood of underinsurance. So to reduce that, we should really look at the changes in material and labor costs for reconstruction, because those costs are always changing, especially with what we're experiencing right now with inflation. So I know that this provided a lot of information, and I think that it's a big challenge, but I do believe that there are so many solutions out there that can really change kind of the situation that we're in. And I found a really interesting article in the Journal of Forest Ecosystems that said that it's not just one size fits all approach. There's so many different things that we can do, and the best strategy for communities is really to look at different actions to manage that loss. So researchers actually found that adaptation transformation takes place when public agencies work together with private citizens to change the wildfire suppression model and really look at a long-term perspective of how you can efficiently reduce the risk. So here to talk about a couple of my alternatives and solutions, I think that the theme that is running through all of them is the importance of proactive maintenance. So one alternative is studying the housing arrangement and vegetation-related factors. So there was a fire in 2018, the Camp Fire, that really decimated the town of Paradise, and they looked at the home losses, and the researchers recommended that in the future, there is a possibility of looking at home windows and sidings that are close to neighboring structures and really also eliminating near home combustibles. So they're saying, hey, let's really look at some of the home infrastructure and see how we can really provide a better option for folks. Another alternative is giving individuals the opportunity, training, and tools to have proactive maintenance of landscape. So that would mean that homeowners, homeowner associations, property managers can take classes together and be given resources in terms of how to manage their landscape better for fire escaping. And I also believe in the importance of coordinated response among different institutions. And so giving those groups resources for trimming trees or revamping their landscape to have wildfire mitigation methods in place. On an institutional level, we're looking at local public agencies, city and county levels. All of these groups can really take part in wildfire mitigation to ensure that agency-owned lands are properly inspected and cleared before wildfire season. And the last one that I encouraged or thought about was providing subsidies. I think that money always talks. It's always a great incentive to help people change their habits and perceptions. And so I I just want to say that I think that this is a really important issue, and that concludes my presentation. Thank you everyone for listening today, and I'm happy to answer any questions that you might have.
Great. Thank you, Connie. Any questions or anything at all for Connie? I think you're right. Money does talk. We see that all the time in policy, and so I think subsidies do oftentimes accomplish what we want them to accomplish, because they're very fiscally appealing to folks. So money does talk. Very well done. Thank you. So Anna, Elena, Adderley, and Connie. Perfect. That's exactly what we're looking for at the presentations. And so thank you to you for getting us started and setting a very high standard for all others to follow. So I really do appreciate that. So this is how we're doing our presentations. And so you've got a good guide to go by for next week. Our entire session next week on the 9th will be devoted to the remaining presentations. I think that's 16 or so. So it'll probably be a longer than normal session. We may go past our 9:45 next week. If we keep our presentations about 10 minutes each next week, the math tells me it should work, and we should get through all presentations. If for some reason we're running really short on time and we have a few presentations left, I have a solution in my back pocket I'm going to hold on to and not tell you about right now. But if we do need it, I have a solution that we can use to fix the problem if it becomes a problem next week. But I do think we can get through all of our presentations in next week's session. So that's it for tonight. And you get out a few minutes early, a couple minutes early at least. Again, please do remember, if you haven't done Beach Board essay number 4 yet, get that turned in by the end of tonight. And then for next Thursday, you've got your final report. Any questions, feel free to email and ask me. And then your Beach Board essay number 5, which is just the chosen alternative portion of your final report. Okay. All right. Thanks everyone for being here. Thanks again to our 4 presenters for doing a great job. I'll have the recording up by tomorrow morning if you want to go back and watch any of this. Otherwise, we'll be back together again for our final session next Thursday on the 9th. Okay. Thanks everyone. Have a great remaining week and have a great weekend.
Good night, everyone.
Thank you. Good night.
Thank you.